The Epilepsy Foundation is pleased to share with you an educational webinar, Beyond Seizures, Comorbidities in Childhood Epilepsy. The mission of the Epilepsy Foundation is to lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. Next slide, please. My name is Dr. Elaine Wirrel, and I would like to extend a warm welcome to everyone who has joined us this evening. It is wonderful to have you with us tonight as we address this important topic of comorbidities in childhood epilepsy. I'd like to review with you the format for tonight's webinar. During the speaker presentations, all phone lines will be muted. We would like to encourage everyone to submit their questions at any time during the webinar. To do so, type your questions into the question window on the GoToWebinar panel and click Send. We will read your questions aloud during the question and answer portion of the webinar. Please try to keep your questions general in nature as the webinar is intended for educational purposes. This webinar does not take the place of individual medical advice. This webinar will be recorded and available for viewing and listening on epilepsy.com. The Epilepsy Foundation is working to provide information and education that serves the spectrum of individuals and families impacted by epilepsy. Often, when you have a question about your health or your loved one's health, you may hear or read things that you are not sure how to interpret. The Foundation's webinar education series aims to bring together expert clinicians and scientists who can share with you up-to-date and accurate information to help answer your questions. Let's take a few moments to go over what the word comorbidity means. When a person's health is impacted by more than one condition at the same time, the conditions are considered to be comorbid. Essentially, this word reflects that a single person can have conditions that occur together that have an impact on their health. Some comorbidities occur purely by chance, but certain comorbidities in other situations occur at higher than chance levels. Tonight, we are going to take a closer look at some of the comorbidities which occur most frequently in childhood epilepsy. You may be wondering why it is important to stop and consider comorbidities in epilepsy. There are a number of reasons to do so, one being that there are many other conditions that can happen along with epilepsy. And you can see them in this diagram here, encircling epilepsy in the center. We also know the relationship between these conditions and epilepsy can be complicated. Taking time to stop and consider comorbidities is important because they have the potential to influence development, learning, treatment approaches, and treatment successes in epilepsy. We also know comorbidities can influence a child's quality of life and the way a family will function from day to day. Often, these conditions can be more disabling than seizures. To help us understand the issues beyond seizures, we are very fortunate to have with us our two wonderful guest speakers. It is my great pleasure and honor to introduce to you our guest speakers this evening. Dr. Elaine Wirrel is the Director of Pediatric Epilepsy and Professor of Neurology at the Mayo Clinic in Rochester, Minnesota. She completed medical school at the University of British Columbia and her pediatric neurology training at Dalhousie University in Halifax, Nova Scotia. She is the co-chair of the Nosology and Status Epilepticus Task Force and a member of the Psychiatric Issues in Pediatric Epilepsy Task Force of the International League Against Epilepsy. She is also the chair of the Pediatric Content Committee at the American Epilepsy Society and a member of the Medical Advisory Board for the Dravet Syndrome Foundation. Dr. Wirrel's main research interests are early onset, medically intractable epilepsies and epileptic encephalopathies. She is recognized nationally and internationally as a leader for her clinical and scientific work in pediatric epilepsy. We're so very fortunate to also have Dr. Wirrel leading and supporting the Epilepsy Foundation's efforts in online patient and professional education as the co-editor-in-chief of epilepsy.com. Welcome, Dr. Wirrel. Thank you for sharing your time and extensive experience in caring for families impacted by epilepsy with our community this evening.
Thanks very much. It's a pleasure.
I am also so pleased to introduce to everyone Dr. Eva Alden. Dr. Eva Alden is currently a clinical neuropsychology postdoctoral fellow at the Mayo Clinic in Rochester, Minnesota. She completed her graduate training in clinical psychology at Northwestern University in Chicago. Dr. Alden came to the Mayo Clinic after completing her residency at the University of Florida, which included specialized training in neuropsychological assessment of epilepsy. Her current research interests include improving functional and psychosocial outcomes in patients with epilepsy, as well as transitioning adolescents with epilepsy from pediatric to adult medical care. Welcome, Dr. Alden, and thank you for sharing your time and knowledge with us this evening.
Thank you.
The following are disclosures for our speakers this evening. At this point, I'm going to hand things over to Drs. Wirrel and Alden, who will help guide us through the most common comorbidities, the symptoms, diagnosis, management, and risk for comorbidities. They will also share with us what can influence comorbidities, and also help us answer the question, does better seizure control help when it comes to comorbidities? With that, I'll turn things over now to Dr. Wirrel.
Thank you very much, and welcome to everyone who has joined us. So today we're going to really talk about the non-seizure manifestations of epilepsy. And I think what we've really learned over the last number of years is that epilepsy is clearly not all about just the seizures. The seizures are probably the tip of the iceberg, and as you see from this diagram, there's a lot of other issues that are seen in many children and teens with epilepsy that are really important to recognize and to address. So issues with academic underachievement, issues with unemployment or underemployment, intellectual disability, mood disorders, ADHD and behavior problems, independence issues, driving issues for teenagers, sleep disorders, autism, bone health, and then injury and sudden death that can also occur with seizures. And we're going to try and touch on most of these today. So first of all, how common are these comorbidities? This was a nice study that was done out of Norway, and this was a patient registry, and they looked at over 1 million children in Norway, and they followed these kids over a 17-year period. And what they found is they compared the comorbidities in kids who had epilepsy, and they compared that to the same comorbidities in children without epilepsy. Within the epilepsy group, they defined epilepsy as complicated epilepsy. That's indicated here as epilepsy plus C. And complicated epilepsy were kids who had epilepsy plus something else. So epilepsy with intellectual disability, epilepsy with autism, epilepsy with cerebral palsy. And then they had the uncomplicated epilepsy group, that's the epilepsy minus C, and these kids just had epilepsy. They were otherwise normal cognition. They did not have any motor disabilities like cerebral palsy. And then they looked at how much more common were these disorders in kids with epilepsy compared to the general population. And you can see here in the complicated epilepsy group compared to the general population, certainly much, much higher levels of these associated comorbidities in that group. But even if we look at the next column over here, the epilepsy without other complications, you can see here a over 3-fold increased risk of ADHD, an over 2-fold increased risk of behavior or emotional disorders, about a 2-fold increased risk of anxiety, and a 1.2 increased risk of depression. So while these comorbidities are certainly more common in kids with complicated epilepsy, they also occur in kids with uncomplicated epilepsy. The other thing that we know is that these comorbidities present very, very early. This was a study that assessed children at the time of their first assessment for epilepsy, and they compared these kids to their to matched controls. And all of these kids were in mainstream school. They excluded kids who had other neurological disorders or chronic disease. And you can see here that children with epilepsy compared to controls had higher rates of behavior problems, attention problems, slower reaction times, greater issues with learning and greater issues with other academic problems compared to children who did not have epilepsy. So this is something that is present very, very early on. Now we know that epilepsy, particularly if it starts very, very early in life, likely has a bigger impact on comorbidities. This was a nice study that was done by Ann Berg out of Chicago. And what she did is she looked at how old were the kids when epilepsy started, what was the proportion of children with normal cognition, and then she looked at whether those children had epilepsy that was easily controlled by drugs, and that's shown here by the black diamonds, or whether these kids had epilepsy that was not controlled by drugs, so drug-resistant epilepsy, and that's shown by the gray squares. And you can see here the very young children who have epilepsy that is not easily controlled by medication certainly have the biggest impact on their learning. The vast majority of those children have significant issues with cognitive and learning problems.
So in addition, we also know that children with epilepsy who do have learning difficulties, it also has a negative impact on their psychosocial and adaptive functioning. It can affect all of these areas, and typically we do see it impact at least 2 or more. So we know that learning difficulties not only have an impact on functioning during childhood, but also long-term adult outcomes. And this is actually more true of children with epilepsy than other chronic childhood diseases. So this really highlights the need to recognize the signs and symptoms of these difficulties early on and intervene as soon as we can in order to maximize learning potential.
So I wanted to highlight a couple of studies that have actually looked at outcomes in children with epilepsy. So the first study was out of Finland, and they looked at 81 young adults who had had onset of epilepsy in childhood, and they compared them to cases who did not have epilepsy. And they found that the kids who had had epilepsy were more likely to have lack of education beyond a primary school level. They were less likely to have achieved any type of vocational education. And they also had a greater likelihood of living dependently, either living on a disability pension or still remaining with their parents as young adults than did the kids without epilepsy. And they found that learning disabilities predicted for poor education and vocational outcome, but they found that even those without learning disabilities were still more likely to be living dependently. A second study was by the Campfields out of Nova Scotia, Canada, and they looked at 337 normal children with epilepsy. And what they found, looking at their outcome at school age, they were more likely to have failed a grade. They were more likely to have required consultation with a mental health professional, either a psychologist or a psychiatrist, and they were more likely to be treated on some type of medication for a psychiatric disorder. Looking at their outcome in adulthood, they were more likely to be unemployed, higher rates of social isolation. Women had quite high rates of inadvertent pregnancy, and about 2% had criminal conviction. And then another study out of Nova Scotia as well that I was involved in actually during my training, we looked at young adults who had absence epilepsy in childhood, and we compared them to another group of young adults who had had juvenile rheumatoid arthritis. And we did that because we really wanted to compare sort of a chronic disease control group. We looked at a number of different areas, but what we found was that children or young adults who had had epilepsy in childhood had greater difficulties in their academic and personal lives and greater behavior problems. And that even those whose epilepsy had gone away, they had outgrown their epilepsy, they still had more difficulties in adult life than the arthritis group. And then a third study that has recently come out actually by Christine Baca looking at children with epilepsy and their siblings. What they found was that if you had uncomplicated epilepsy, so that meant epilepsy again without any type of intellectual disability, if you had remission of your uncomplicated epilepsy, you actually did as well as your siblings. So that was certainly good news. But if you were not in remission, even if your epilepsy was uncomplicated, you had a lower likelihood of graduating high school, greater rates of unemployment or underemployment, and less likely to live independently. If you had complicated epilepsy, so intellectual disability, autism, CP, things like that, not surprisingly, it didn't really matter. So if you had remission of your epilepsy, you still did worse than your siblings. However, if you did not have remission, you actually did worse than if you did have remission.
So Dr. Wirrel's provided an excellent overview of some of the comorbidities and their associated long-term outcomes. Really, the point I'd like to make is that some of these comorbidities actually have a more significant impact on overall quality of life than the seizures themselves. So it's just as important that we address these in childhood as well as getting good seizure control.
So let's look now at the different potential causes for these comorbidities. So one of the big factors that we think about is underlying brain disorders. So many times, particularly with the early onset severe epilepsies that don't respond well to medication, those epilepsies are often due to pretty widespread brain abnormalities. So you can either have developmental brain changes, you can have prior brain injury, or you could have a genetic cause. And in some of those cases, even if we really improve seizure control, that doesn't necessarily take away those comorbidities. Then we look at various epilepsy syndromes, and we know that the risk of these comorbidities is certainly highest in those early onset epilepsies that are not responsive to medication. But we know that we can also see those in even more what we call benign or generally more well-behaved epilepsy syndromes. So benign epilepsy of childhood with central temporal spikes or benign Rolandic epilepsy, those children have higher rates of language problems. In juvenile myoclonic epilepsy, which typically comes on in the teenage years, those patients often have more issues with inattention, with memory. And then in childhood absence epilepsy, again, they can have greater difficulties with language and also greater rates of inattention and attention deficit disorder. Another thing we look at is a number of different epilepsy characteristics. So we know that epilepsy that starts early in life is higher likelihood to be associated with various comorbidities. We know that in some cases, very frequent seizure discharges on EEG can be associated with greater learning problems. We know that children who have epilepsy for longer durations have more problems. And I think we all know that the medications that we use to treat seizures, while I think that they are necessary in most cases, many of those medications also have side effects that can certainly exacerbate different behavior problems or learning problems. Furthermore, when we look at a child with epilepsy, this is a bit of a moving target. So we know that brain development is very, very active in all children. And so if we look at healthy children, what we typically see, and that's shown here in the first set of pictures, we see a reduction in gray matter and we see an expansion of white matter. So red shows thicker gray matter and blue shows thinner gray matter. And this is what we see as the child ages from 5 up to 22 years of age. Looking at kids with epilepsy, there is a bit of a change in how their brain develops. So they actually have less of this gray matter thinning, and they have less of this white matter expansion. So that also probably plays a role in why they have greater rates of these comorbidities. One of the most concerning types of epilepsy is what we call an epileptic encephalopathy. So these are disorders where there's very, very frequent seizures. And as you can see here on this EEG, very, very frequent and almost continuous discharges. And we know that in those situations, the very frequent seizures and the nearly continuous discharges can in fact worsen learning problems. And we think that what happens is that this frequent discharge or continuous discharge really disrupts the normal circuits in the brain that support learning. And in these cases, it is really important to get better seizure control and also to really quieten down the EEG in order to allow that child to achieve their potential.
So I'll talk a little bit about some of the cognitive or intellectual difficulties when it comes to comorbidities. So the first is intellectual disability, which occurs very early during development and includes problems in intellectual and adaptive functioning. So by intellectual functioning, we mean difficulty with thinking or what we call cognition, and this does impact their ability to learn new information. And then adaptive functioning is things like communication, social skills, and independence. And that really impedes their ability to do things at a developmentally appropriate level. So it could be something as simple as learning how to tie their shoes, brush their teeth in the morning, or start to get their routine together before they go to school. In order to diagnose this, you do need a clinical assessment with psychological testing, including IQ testing. The prevalence, unfortunately, is slightly skewed towards more severe intellectual disability in individuals with epilepsy. We tend to think of ID along a range from mild to severe. Some of the predictors that can make it more severe are actually more closely related to seizure severity and include the syndromes that Dr. Wirrel has already reviewed. So learning disabilities are slightly different. So when we think of a specific learning disorder, this manifests typically in one area of academic functioning, and it looks a little bit different depending on what subject the child is having difficulty with. So for example, reading might manifest as difficulty with reading comprehension. If it was math, it could be difficulty performing calculations or learning new concepts. This is typically identified either by teachers or parents and low grades, and testing is required for a formal diagnosis and connection with services. I'll talk a little bit more about accommodations later on in this talk, but for specific learning disorders in particular, tutoring at the school is one really important intervention. So in children with epilepsy, we know that they have greater academic difficulty even after we take IQ into account. So what this means that even if their IQ is normal, we often see difficulty in these learning areas compared to the general population. So we know that baseline IQ or intellectual ability is related to academic achievement, but there are things that we call moderators, which are essentially factors that can have an influence on this relationship. And I just want to make the point that seizure-related variables in this instance are not an important moderating factor. What we do know is an important moderating factor are things like the family environment, parental education. So structure at home and organization can be really important areas to intervene to modify this. So I'll talk a little about autism spectrum disorder, which is another developmental disorder that involves social communication and unusual behavior changes. Some of the earliest signs of autism are delayed language, failure to use gestures, so pointing, and poor eye contact. As kids age, you start to see some of the more classic signs of autism, so you'll see those repetitive, purposeless behaviors like hand flapping or repetitive rocking as well. And again, you just don't see the same type of communication skills that you would expect for that child's developmental age. The gold standard for diagnosing autism is called the Autism Diagnostic Observation Schedule, as well as a clinical interview. So if you are concerned about autism, you want to look for a provider that is trained in the ADOS because it does require quite a bit of training to administer. So this is by no means a comprehensive list of treatments for autism, but these are some that we believe based on evidence and research are effective. So the first is applied behavior analysis, and then the Early Start Denver model, which can be helpful for older children with ASD. And then below, I've got a list of some resources. The first is an Early Start for Autism, which is, not sure what happened.
Sorry about that. I think
One second. So an Early Start for Your Child with Autism is a book recommended by our pediatric neuropsychologist here who specializes in autism diagnostic. And then Autism Speaks as well. The link at the bottom actually takes you to a PDF called the First 100 Days Kit, which you can download for free. Okay.
So we know that autism spectrum disorder is certainly not seen in every child with epilepsy, but the risk is higher. So the risk is about 7.4-fold higher in children with epilepsy than in the general population. And risk factors for autism spectrum disorder include intellectual disability, which is probably the biggest risk factor. Other risk factors include children with early onset epilepsy, particularly if that epilepsy starts in the first year of life. If it is drug resistant, we know that certain seizure types, such as infantile spasms or West syndrome, are higher risk. And then we know that certain causes, things like tuberous sclerosis complex or some genetic causes, also increase the risk of autism in children.
So moving on to attention deficit hyperactivity disorder, some of the primary symptoms we look for are things like limited attention span, impulsivity, speaking out of turn, and this can result in poor grades and loss of friends. The point that I really want to make here is that in order to meet diagnostic criteria for ADHD, the symptoms have to occur in at least 2 settings and cause functional impairment. So it's not enough to diagnose a kid who's just having trouble paying attention in class with ADHD. It would need to cause potentially lower grades or also impact their social skills at school with their peers or at home with their siblings. In terms of treatment, We have good evidence that medication can be both safe and effective at managing ADHD symptoms, even in children with epilepsy, and I think Dr. Wirrel is going to touch on that a little bit more. We also know that there are good cognitive strategies like structured work breaks. ADHD is very common in children with epilepsy. It can affect up to 1 in 3, and it's often present at the time of or even before the first seizure.
There are some key differences, however, in ADHD in children with epilepsy and those without epilepsy. So one of the big differences is that there are a number of different subtypes of ADHD. There's one called the inattentive subtype, where the child simply doesn't pay attention but is not very hyperactive. And this is the one that is actually most common in children with epilepsy. What that means is that these kids are quietly sitting in their desk, not paying attention, as opposed to running around the classroom disrupting everything. And so what that means is that this is a type of ADHD that is less likely to be recognized early on by the teacher, and many of these kids are picked up later. The second difference that we see in children with epilepsy is that boys and girls are nearly equally affected. If you look at children with ADHD who do not have epilepsy, this diagnosis is much, much more common in boys, not so in epilepsy. Other risk factors include early age and onset of epilepsy, epilepsy that is drug resistant, so not responding to the usual anti-seizure medicines, epilepsy that is either generalized, including juvenile myoclonic epilepsy or childhood absence epilepsy, or epilepsy that starts in the frontal lobe. And then we know that certain anti-seizure medications can also worsen the child's attention and focus. These can include things like Depakote or valproic acid, phenobarbital, and Keppra or levetiracetam. So it's really important that we look for this. It is very common in kids with epilepsy, and it is often unrecognized and untreated. And if it's untreated, that really can have a negative impact on the ability of that child to achieve what they should be able to achieve. We'll talk a little bit about this in a while, but there is an erroneous fear that stimulants, which is our usual medications we use for ADHD, can actually worsen epilepsy. And I think that has now clearly been disproved. Stimulants can be very, very effective and should not be avoided in children with epilepsy.
So we've mentioned academic accommodations as a treatment or an area to intervene sort of for each of these different learning difficulties. So I'll talk briefly about an IEP and a 504 plan. This could really be a lecture in and of itself. So an IEP stands for an individualized education plan, and it describes how the school will provide an eligible student with a free, appropriate public education. A 504 plan provides accommodations for eligible students with a documented physical or mental disability. Both of these are covered under federal law, but under slightly different pieces of legislation. So this chart can be helpful to delineate the differences. I won't go over everything in detail, but I'll just kind of direct your attention to the fourth line down, what is included. So with the IEP, specialized education services, accommodations, and related services. With the 504 plan, you're really getting accommodations and modifications. The age limits are slightly different. So in the IEP plan, it's offered through the 12th grade. 504 plans do not have an age limit. Where the plans can be used. IEP can only be used educationally through the 12th grade and will not transfer to college. A 504 plan will transfer to college and can also provide work accommodations for eligible recipients. So we're going to shift gears a little bit and talk about behavior and emotional problems in children with epilepsy. So we know that individuals with epilepsy are more likely to have behavioral problems at an earlier age compared to other children. The symptoms can vary quite a bit, and I'll talk about this a little bit more specifically when I talk about anxiety and depression, but we do see higher rates of what we call internalizing problems, and this is really just a fancy term we use as psychologists, and what we mean is the emotional distress is experienced inwardly, so you might see more withdrawal, complaints of physical symptoms. We don't necessarily see higher rates of externalizing problems or outward symptoms, so we don't necessarily see more fighting or oppositional behavior or arguing. The first line treatments for behavior problems are really behavioral therapies. So one is parent-child interaction therapy and parenting interventions. Medication can be considered in severe cases, but we would never recommend this in place of one of those behavioral therapies. So mood disorders are also quite common. Depression is common, which includes sadness, withdrawal, low motivation, irritability. I want to talk a bit about the irritability piece because often I think this gets missed. So irritability is actually thought to be related to depression, particularly as they age into the teenage years, but we often misattribute that to normal teenage behavior, but it is an important warning sign to look out for. Anxiety includes persistent worry that interferes with daily activities, as well as some of those more physical symptoms. I'll talk more about the warning signs later, but you want to just kind of be aware if you're seeing more of these overwhelming feelings that are coming out, or a child is complaining more about things like headaches and stomach aches. Screening for this is often done at routine medical appointments. It can also be done through self-report, collateral report from teachers about their behavior at school, or if you've been referred to a mental health provider before. Risk factors for developing depression and anxiety include low coping skills, low perceived social support, or low self-efficacy, which essentially means feeling like you don't have a lot of control over what happens. So we know that depression is higher in persons with epilepsy. The lifetime prevalence of major depressive disorder is 17.4% versus the general population, which is 10.7%. This can often predate seizure onset, and children are at an increased risk. So development of depression is less related to epilepsy variables, so things like seizure severity, having multiple types of seizures, and is more related to psychosocial factors. So like I was mentioning on that last slide, the social supports, the coping skills, as well as genetic predisposition. So if there's any family history of depression or other psychiatric disorder, that would put someone at increased risk. Anxiety is also quite common, so 16 to 36% of children with epilepsy can have elevated scores on screening tools. Again, it's minimally correlated with epilepsy variables, and more so correlated with learning disorders and those psychosocial factors. Anxiety in particular can be tricky because they, again, have more of that inward manifestation of symptoms that they're not necessarily able to talk about, particularly in younger children. You know, they might feel nervous, but they don't necessarily have the vocabulary to say that. So if you're noticing a lot of social withdrawal, perhaps they're not interacting with parents or siblings at home as much as they typically would, then those can be some warning signs to look out for. So interventions for mood and behavior problems, medication can be safe and effective. As a psychologist, of course, I like to think that individual and family therapy are appropriate adjunct treatments or first-line treatments as well. We know cognitive therapy is effective at reducing both symptoms of depression and anxiety, and relaxation training as well. We also know from existing research studies that improving symptom management actually is associated with a reduction in seizure frequency. So I want to touch briefly on suicide risk. We know from the literature that adults with epilepsy are at a greater risk of suicide than the general population. But this actually has not been well studied in children. However, we do have reason to believe they may be at increased risk. So some things that you can look for are these behavior changes that I've kind of been touching on all along in the last few slides. If there's increased substance use or more risk-taking behavior, if children start to give things away, maybe, you know, they're giving away favorite toys, or saying things like, I really feel like a burden to my family. Those are signs of concern. So what do you do about it? You have to talk about it. And this can be really uncomfortable, but it is the best way to prevent suicide from happening. And so I've kind of put this diagram on the right up just as a helpful schematic. And this is not meant to be wait till we get into crisis. This is a prevent the crisis from happening. So it's about looking for warning signs in your child, talking about them, and developing a plan together about how you're going to address them. So if you take away nothing from this last portion of the talk, I want you to pay attention to the 2 F's, which are the fight or flight response. So the fight response is those externalizing behaviors that I've been talking about. So again, the acting out, not listening, getting into trouble at school. And the flight response, it would be the internalizing behaviors. So noticing that they're more withdrawn than they typically would be, they're not as motivated, or they're complaining more of those physical or somatic symptoms.
So we're going to switch gears a little bit and talk about sleep problems. And sleep problems, I think, are really important to look for because they can compound other comorbidities. If you don't sleep very well, you're not going to be doing as well in school. You're going to have higher rates of anxiety, higher rates of depression. You're going to be less able to pay attention to your schoolwork, and you may show greater problems with inattention and focus. And furthermore, if you have sleep problems, that is a big factor in preventing you from getting the seizure control that you otherwise would be able to. So this is a really, really important comorbidity to assess. It is often reported if you actually ask families, does your child have any difficulties in sleep? The answer is very, very frequently yes. We know that about 81% of young children with epilepsy actually score in the at-risk range if we give the family sleep questionnaires. And there's a number of different factors that actually that cause the sleep problems in kids with epilepsy. So some of our anti-seizure medications can actually change different sleep cycles and makes sleep disruption more problematic. We know that older children with epilepsy, as well as younger children with epilepsy and other neurological problems like cerebral palsy, can have increased rates of obstructive sleep apnea that can cause recurrent arousals through the night, and so those kids never really get a good night's sleep. Melatonin is the hormone in the brain that actually regulates sleep, and we know that that is disrupted, the release of that is disrupted in children who have epilepsy. And as well, we know that many of our children with epilepsy have quite frequent discharges in sleep, and we think that that also can potentially prevent them from getting a really good night's sleep. And then there's some psychosocial issues. Obviously, if you're a parent and your child is having frequent nighttime seizures, and you've heard about issues with potential injury or even death that can happen as a result of seizures, it's normal that you're going to be anxious about that. And so there's going to be more parent-child interactions at night. Oftentimes we see higher rates of the children actually co-sleeping, and that can cause problems in many cases because neither the child nor the parent gets a good night's sleep. And then there's also issues of child anxiety. What if I have a seizure at night and then they're not sleeping as well? Moving on to bone health, we know again that children with epilepsy are at higher rates of bone health problems. So again, that could be several factors leading to that. Many of our anti-seizure medications can impact levels of vitamin D. Vitamin D is important to keep bones healthy. The ketogenic diet also can impact bone health negatively. Many of our children with epilepsy have restricted sun exposure. They may not be outside as often. And even in our healthy children without epilepsy, when they go outside, oftentimes you're lathered with sunscreen and you're covered head to toe. And so even in our kids without epilepsy, many of those children are vitamin D deficient. And then other factors that can exacerbate that are things like cerebral palsy or malnutrition. So we know that children with epilepsy do have higher rates of overall fractures and higher rates of long bone fractures. And in order to prevent this, I strongly believe that every child with epilepsy should be on a supplemental vitamin D dose, somewhere between 400 units or 1,000 units per day to reduce the risk of fractures. That's particularly important in children who have been on long-term anti-seizure medications, those who live in the northern part of the US as opposed to the southern US, and those who are on a ketogenic diet or have other risk factors like cerebral palsy or malnutrition. Moving on to physical fitness, we know that physical fitness is actually a really, physical activity is a really important factor just in allowing our kids to socialize and also to keep them mentally healthy. And we know that children with epilepsy may be more limited in sports activities due to fears of injury. What if they have a seizure when they're participating in a sports activity? And that can certainly limit their ability to participate in these activities. Lack of physical fitness, we know down the road, will predispose to other comorbidities in adulthood. So if you're poorly fit, you're going to be at higher risk of heart disease, higher risk of stroke, higher risk of diabetes, and higher risk of arthritis. And so to prevent this and really allow our children to be healthy down the road, I think we really do need to be paying attention to this as well. So physical activity has been studied in children with epilepsy. This was a study that compared normal children with epilepsy to their sibling controls. And what was found is that teens, but not the younger children with epilepsy, were less physically active than their age-matched controls, and they were more likely to have a body mass index in the significantly overweight range than were the age-matched controls. So again, really important in our teens with epilepsy to ensure that they actually make healthy choices, that they stay physically fit. Moving on to epilepsy-related injuries. This is a big concern for many families. So a number of studies have actually looked at this. The biggest study was the first one by Beggy and colleagues, and this was actually a study that included not only children but adults. And they did document that there were higher accident rates in persons with epilepsy than persons who did not have epilepsy. The other three studies here were done only in children. So the study by Prasad was out of the UK, and they found higher rates of fractures as well as higher rates of burns in those who had epilepsy. The third study, Lugunju, was out of Africa, and they found higher rates of injury in those with epilepsy, and they actually correlated injury rates with greater seizure frequency, and they noted that children who were on multiple medications also had higher rates of injury. And then the final study was out of Canada. They looked at a group of children who had epilepsy, and they found that if you had drug-resistant epilepsy, you had much higher injury rates than if you had drug-responsive epilepsy. So epilepsy-related injuries are important, and it is important to discuss with your healthcare provider what are reasonable limitations for your child. Obviously, we want to keep them safe. We don't want them to be put at risk of injury, but we also want them to live as normal a life as possible, and there's really a balance there. One of the biggest concerns to me as a child neurologist is drowning injury. This is the injury that is most likely to result in death or disability in persons with epilepsy. So a study out of Australia by Franklin looked at all drowning deaths, and they found that the risk of drowning for children with epilepsy was 2.4 to 5.8 times higher than children without epilepsy. So we know that our kids with epilepsy are at risk of this. And then a study out of Washington a number of years back found that children with epilepsy were more likely to die of drowning actually around the home. So if they died of drowning, they were more likely to die of drowning in the bathtub or in the pool. These are very, very preventable, and this is why your neurologists often tell you your child should not be in a bath or in a pool unsupervised. So to review detecting comorbidities, we really know that all children with epilepsy are at risk. And there are a number of different techniques that we have to detect these comorbidities. I think really importantly, asking the questions. And this can be done by the physician, this can be done by the nurse, the teachers, daycare providers, or peers. You want to be requesting screening if you're concerned. Your child may have one of these comorbidities. I think it's an important thing to bring up with your healthcare provider. And then certainly if there are concerns on those screening or significant concerns that you or others have about your child, requesting referral to the appropriate provider that can help you address those issues. If it's a mental health disorder, potentially psychiatry or psychology. If you're concerned about sleep, potentially talking to a sleep specialist.
So I think in the interest of time, I'll skip the questions to ask, but the next two slides basically have some things that you can ask yourself and then also continue to have those discussions with your providers. But I want to touch on sort of what the benefits of working with a psychologist, psychiatrist, or social worker are and what different things they can provide for you. So these are just here for reference. So a psychologist can assess for mood disorders and assist parent and child with adaptive coping using different types of behavioral therapies that I've mentioned previously. They can also help with promoting healthy socialization. If you're looking to have a diagnostic assessment for a cognitive disorder, I would encourage you to see a neuropsychologist, particularly, again, if you're looking to get that ADOS testing done for ASD, you need to look for someone who's certified in that. For some of the intervention piece, that can certainly be done by a master's level social worker who is a licensed clinical professional counselor or licensed clinical social worker. Social work is actually a fairly broad field, so social workers actually can also assist families in getting access and service connection in these areas, so supplemental medical insurance, connection to a 504 plan or an IEP, assist with medication costs, referrals to behavioral services in the area, as well as transportation reimbursement. Psychiatry would be appropriate to consult if there is a significant mood or, again, a severe behavioral disturbance. That would be an appropriate person to consult, especially if there's suicidal ideation or you have concerns about thoughts of suicide. ADHD can be often managed by your neurologist or pediatrician, but if they are uncomfortable managing those medications, then you would certainly also want to consult psychiatry. Also, if there's any concerns of a more severe emotional disturbance like psychosis, so you know they're not in touch with reality or they've got some unrealistic thinking, you would definitely want to consult them as well.
So I just wanted to touch briefly on medications for some of the disorders that we had talked about. So one of the biggest concerns that we see in our kids with comorbidities who have epilepsy is there seems to be a great reluctance to start an appropriate medication for some of these comorbidities because of concern that somehow that actually might make the epilepsy worse. I think what that results in is our kids that have these comorbidities are really then not being able to be treated appropriately for those. And that has a very negative impact, I think, on what they can achieve and also their quality of life. ADHD, we had already talked about, it affects about 1 in 3 children with epilepsy. And we know that in children who have epilepsy and ADHD, studies have actually shown that these children respond very nicely to stimulant medications, which are the typical medications that we use for that. And we also know quite clearly now that there is no significant increase in seizure risk when we use these stimulants, particularly methamphetamine or various forms of Ritalin. So these medications are actually quite safe in our kids with epilepsy. Mood disorders also, I think, need to be treated if there are concerns. And our class of medications that we often use for those is something called SSRIs. These are generally very well tolerated and effective in our kids with mood disorders and epilepsy. So a couple of key points to remember. Comorbidities are really the rule, not the exception. And I think gone are the days when we just think about epilepsy and seizures being the only symptom of that. I think we really need to think about epilepsy, and seizures are one symptom, but there are a lot of other symptoms: depression, ADHD, anxiety, sleep problems. And I think in order to really holistically help the child with epilepsy, we really need to be looking for these other symptoms. We know that kids with complicated epilepsy are at highest risk of these comorbidities, but they can actually occur also in children without any other complicated factors. These comorbidities typically present early. They may actually precede seizure onset. So it's important, I think, that you and your clinician, your health provider, look carefully at your child to see if there are any of these comorbidities present early on, and that needs to be an ongoing assessment. There are multiple factors that influence these comorbidities, and we know that early and better seizure control can also improve outcomes. So we really don't want to forget about the seizures, but we really want to do our best to control the seizures, but also not to forget about these comorbidities.
And so just, you know, a quick wrap-up reminder. So we know that seizure variables predict cognitive comorbidities more so than psychiatric. It's actually the psychosocial piece as well as the family history, genetic risk factors that are more closely related to psychiatric comorbidities. These are also treatable, but early intervention and detection is key in order to improve long-term outcomes and overall quality of life. And I just want to make the point that it's not just about treating the child, but also the family system that child functions within.
So remember, challenges in epilepsy extend beyond seizures, and your epilepsy team can really help with that. It's important to be prepared for clinic visits, to ask questions, to take notes. Many families that come into my clinic actually come with a list of questions, which I really like. It helps us to kind of make sure that all of the questions have been answered. Ask about screening if you have concerns about your child. I think it's okay to bring that up. Share your family history with your child's doctors. If there are concerns about other potential comorbidities, depression, anxiety, that's something they need to know. And share information from the school with your doctor. I think this really is a team that looks after the child, and the school is a really big part of that team. Discuss mental and behavioral health referrals with your epilepsy doctor if you feel your child is struggling. Participate in treatment decisions about your child, and share treatment updates with your child's school nurse and your teachers to maximize your child's potential for learning. Many epilepsy clinics actually have epilepsy nurses that liaise closely with the school. If your child goes for neuropsychological testing, a lot of the neuropsychologists will also provide very valuable feedback to the school. So that can be a very helpful way to address some of these. So I think at this time, I'm going to hand things back over to Dr. Carrie Kopoulos to share with you some ways that you can enlist the help of the Epilepsy Foundation as a partner and a resource for your families.
Thanks so much. Thank you both for the incredibly comprehensive overview that you've provided with us this evening. If we could just flip to the next slide. So as you leave here this evening, you've certainly had a lot of good information to take along with you. And remember that you can revisit this presentation at epilepsy.com. It's recorded and you can go back and listen and view the slides again if you would like to. And you can share that with others as well. If you have more questions about epilepsy and the evaluation of epilepsy, you want to first off speak with your physician or nurse. Discuss those comorbidities with them. That's always your primary place to start. You can also visit epilepsy.com, and that's our website where you can learn more about epilepsy in childhood and comorbidities that go along with it. You can also find resources to help with your communication, both with your doctor and with the school. Another way you can reach out for help from the foundation is to call our 24/7 helpline, where people can assist you. You can ask them about different resources or information. They can mail you information or direct you to information online. They can help guide you to resources close to your home. And they can certainly guide you to an epilepsy center near your home if you'd like to make a connection with an epilepsy center, where oftentimes it's easier to integrate care between an epilepsy provider and other specialists. I want to encourage everyone to call their local Epilepsy Foundation offices as well. There you'll find people who are willing to support you, to get you in touch with different programs that they have locally, support groups for parents, get-togethers for kids, camp programs for children with epilepsy. So it's really important that you reach out to your local foundation as well. I'd like to take a moment to again thank Dr. Wirrel and Dr. Alden for providing us this evening with important information about the extra needs and challenges that can accompany a diagnosis of epilepsy in childhood, and strategies to try to meet needs and work towards the best health outcomes possible, and the best quality of life for children with epilepsy and their families. I'd also like to thank each of you for joining us this evening, and hope you'll join us throughout the year as we aim to provide you with learning opportunities that help to answer your questions and guide you to the resources you need to manage your epilepsy well.